start with the anatomy. We all know that shoulder is a complex structure that articulates multiple bones forming several joints in one frame. If we see the scapula from anterior side, the coracoid process and subscapularic fossa facing anteriorly, where the spine and acromion process facing posteriorly. And regarding humerus, this is the greater tubercle and lesser tubercle and bicipital group in between. All of these are the very important bony landmarks we need to know to evaluate the MR anatomy and pathology as well. The glenohumeral joint articulates in such a way that only the inferior one-third of the humeral head articulates with the glenoid cavity and gives a wide range of mobility, but at the cost of its stability, where the static stabilizer of the glenohumeral joint is maintained by lots of the ligaments. Among them, the superior middle and inferior glenohumeral joint ligaments is very important, and others are the glenoid labrum and coracoacromial arch. And the four rotator cuff muscles named the supraspinatus, infraspinatus, teres minor and subscapularis muscle provides the dynamic stability of the shoulder joint. And all four muscles arise from the scapula and inserted into the great humerus. As they are named, the supra and infraspinatus muscle arise from the supra and infraspinatus fossa, and the small teres minor muscle inserted into from the lateral border of the scapula, and all three inserted into the greater tubercle of humerus. Rather, the anterior subscapular muscle arises from the subscapular fossa and inserted into the lesser tubercle. The supra and infraspinatus muscle supplied by the suprascapular nerve from the superior trunk of the brachial plexus. And if any injury occurred in that part of the nerve, these two muscles suffers from isolated denervation edema. Whereas the teres minor muscle supplied by the axillary nerve and subscapularis muscle supplied by the subscapular nerve arise from the posterior cord of the brachial plexus. The spinatus muscle helps in the initiate the abduction, which ultimately take over by the deltoid. The infraspinatus and teres minor muscle helps in lateral rotation, where the subscapularis muscle helps in adduction and medial rotation. To get the better quality of image, and we need higher SNR, so we should do our scan with a higher magnetic field strength, with a dedicated shoulder coil, with a very thin slices like 3 to 4 millimeter, with or without minimal gap, higher imaging matrix and small field of vision. For MSK, it is up to 12 to 14 centimeter. This patient should be supine, with arms side by side parallel to the body, with a little external rotation, but not much more. The preferred sequences are PD fat set and PD non-fat set, where the PD non-fat sequences are better to demonstrate the anatomy, and T1 and PD non-fat sequences are better to demonstrate marrow, glenoid bone loss and fractures. And to detect the pathology like tendon tear, tendinosis and labral tear or edema, the fluid sensitive sequences like PD fat set, T2 and STEAR images are obtained. Additional, if we look for the infection, tumor or inflammatory arthropathy, additional T1 fat set contrast should be needed. And to diagnose the calcific tendinosis or intralabral degeneration, we take the help of T2 GRE sequences and reduce or minimize the maging angle artifact which occur at the supraspinatus tendon at 55 degree to the static magnetic field due to prominent muscle slip, which appears intermediate in T1 and PD. We have to take the T2 fat set coronal sequence with higher TE, which reduces this artifact. And sometimes the sag oblique T1 PD image should extend medially to cover the muscle belly. Image should start with 3-pen localizer followed by axial image, and from which the coronal oblique and sagittal oblique images are obtained. We start the axial image few slice above from the acromioclavicular joint, go through the glenohumeral joint up to the upper part of the humerus, and we cut the coronal oblique image parallel to the axis of the axial plane or parallel to the tendon of the supraspinatus muscle, and we go for the sagittal oblique image, which is parallel to the glenoid labrum or at the right angle to the axis of the axial image. Along with the tendons of the tendon of the rotator cuff tendons, we also look for the ligaments, labrum, bones, and bursa in all imaging plane. The axial plane is the primary plane for evaluating the subscapularis. This is the coracoid process, and this is the subscapularis muscle, whereas the infraspinatus is looked for posteriorly. But subscapularis tendon also seen in this image here. This is the subscapulary muscle, this is the coracoid process, and also seen in the coronal image. Infraspinatus muscle as well as also seen in the coronal plane, where the bony landmark is the spine. Thus below that, this is the infraspinatus muscle and tendon, and in sag image just below the supraspinatus muscle posteriorly, this is infraspinatus muscle. So in the axial image, what we look for other than the tendons, we also look for the anterior labrum, posterior labrum, middle glenohumeral ligament, biceps tendon, and the bones for the Hill-Sachs deformities. In coronal image is the primary plane for the evaluating the supraspinatus tendon. Bony landmark is acromioclavicular joint. Underneath the supraspinatus muscle and tendon run and inserted into the greater tubercle. If we go more posteriorly or below, here is the spine, and below that we have to look for the infraspinatus muscle. And if we go more anteriorly, that is the coracoid process, and multipinate subscapularis muscle is here. So in the coronal image, we also look for the superior labrum, inferior labrum, inferior glenohumeral ligament, the subacromial bursa followed by subdeltoid bursa, and acromioclavicular joint. In the sag image, we have to cut from medial to lateral or from lateral to medial. The clavicle is the bony landmark is medially, acromion is posteriorly, and the coracoid process is anteriorly. That is the anteromedial. This is the anteromedial area. So this is the subscapularis tendon, outside of which this is the subcoracoid bursa. Below the coracoid process, there is superior subscapularis recess having the communication with the joint cavity, may contain the fluid when there is joint effusion. And posteriorly, there is supras, infra, and teres minor muscle. The most important thing we have to look for in the sagittal image is the acromial shapes. There are 4 acromial shapes. In the type 1, this is the flat inferior surface of the acromion. In the type 2, there is concave acromion surface. These two are considered sometimes as normal variant. But in the type 3, there is a hook-like projection is seen in the acromion, and the type 4, these are the convex under surface of the acromion, and these two are very notorious as they produce impingement on the supraspinatus muscle, resulting degeneration which leads to tear. The MR arthrograph may indicate it when the patient have the chronic shoulder pain but negative routine MR in case of the capsulolabral repair or recurrent rotator cuff tear or partial articular surface tear. Before going to the pathology, have a look for the rotator cuff tendons. If we go further little bit laterally from the acromioclavicular joint, there is the at 12 o'clock position, there is supraspinatus tendon, and posteriorly inferiorly there is infraspinatus, and below which there is teres minor, and in between two there is conjoint tendon, where the supra and infraspinatus tendon fibers are interdigitate here. Anteriorly, this is the biceps, and below which anteriorly there is the subscapularis muscle, where functionally it has two parts. Now the parts of the tendon. This is the footprint or anthesis part, where the tendon inserted into the bony surface, and from the footprint 1 to 1.5 centimeter proximal, there is the critical zone called the hypovascular zone, and most degenerative tear occur here. This is the myotendinous junction. Most traumatic tear occurs here. Now, what we look for in the tendon? We look for is there is any tendinosis or tear. If there is tear, either it is partial thickness or full thickness. In case of partial thickness, either it is in the intrasubstance or either articular side or in the dorsal side. This is the normal supraspinatus tendon. The tendon is made up of the collagenous fibers with tightly bound water molecules within, give the MR appearance appear as jet black appearance or hypointense appearance. When there is degeneration or color degeneration occurs, the collagen fibers become disoriented, and loosely bound water molecules give the intermediate signal intensity in the MR image. When there is tear occur, there is complete disruption or partial disruption of the collagenous fibers with freely movement of water molecules gives the fluid signal intensity in case of tear. This is the supraspinatus tendon degeneration, which is where the normal thickness of the supraspinatus tendon is 2 to 4 millimeter, but when there is degeneration, it becomes thickened, and intermediate signal intensity in both T1 and T2. But look, there is the subdeltoid or subacromial bursa. If we compare the signal intensity with the bursal fluid, it's not as bright as this bursa, so it considered as a tendinosis. Sometimes the mucoid material tracked down into the least resistant area up to the musculotendinous junction, the formation of the cystic changes. Here the subscapularis muscle tendinosis is seen, where the associated with ganglion cyst in the musculotendinous junction. Here, the hyperintense signal change is seen in the critical zone of the supraspinatus muscle in PD sequences, where we take the PD non-fat fat set sequences, which is more bright with articular surface fraying, but less bright than the adjacent bursal fluid and considered as tendinosis. And sometimes the tendon, rather than the tendon degeneration, there is deposition of calcium hydroxyapatite occur in the rotator cuff tendons due to avascular change or trauma or abnormal calcium metabolism, which is more seen in the supraspinatus muscle rather than other tendon, and associated with or involvement with soft tissue like capsule or bursa, which appear as a all sequences hypointense signal changes in all sequences, or hypointense signal in all sequences, and we look for the T2 GRE image as this calcification appears there as a blooming effect. Here the deposition of calcium in the supraspinatus tendon, which if we correlate with the plain X-ray, there is calcium deposition is seen along the course of the supraspinatus tendon. In the infraspinatus muscle, in the coronal image and in the axial image, there is deposition of the calcium associated with diffuse edema within the muscle. Here, within the deposition of calcium in the tendon may extend into the bursa, resulting the inflammation of the bursa, causing accumulation of fluid within the bursa as well as joint cavity. This occurs due to acute exacerbation of the calcific tendinitis, and patient may present with sudden severe acute shoulder pain. And tendinopathy, sometimes the tendinopathy is complicated by partial tear. Here there is degenerated tendon of the supraspinatus, but at the close to the articular surface, if we see there is the fluid signal intensity area is seen as compared to hyperintense with the bursal fluid. This is caused due to acute partial tear in degenerated tendon. Now, we already discussed about the cause of the tears. The most commonest cause is the age-related degeneration, and others are vascular, but there are some extrinsic factors also, like acromial spur or severe osteoarthritic change in the acromioclavicular joint, or sacromegaly, or due to repeated use, or trauma may be also a cause. Now start with the intrasubstance partial tear. This is the high signal linear signal intensity area seen within the substance of the supraspinatus, as bright as associated bursal fluid. This is the partial tear. Now the articular surface tear, where the tear facing the articular, involving the articular surface, sparing the bursal surface. Here the articular surface partial thickness tear associated with the bursal fluid. This is the rim tear. This is the small articular surface partial thickness tear involving the most of the anterior fiber of supraspinatus, which is more evident in this edge image. This is very close to the biceps tendon. Now the bursal surface tear. This tear facing the, involving the bursal fibers, sparing the articular fiber. Bursal surface tear continuous with the subacromion and as well as subdeltoid bursa. Here the hyperintense signal change is seen involving the articular surface as well as bursal surface, but some fibers, normal fibers, goes to in between. When sometimes the partial tear not filled with the joint fluid, sometimes it may there is accumulation of that granulation tissue. In that case, we have to go for T1 GAD image or T1 contrast image to see the enhancement of the granulation tissue, or go for the MR arthrography. As contrast may fill the tear if articular surface of the tendon communicates with the joint. The slide is not changing. Why? Hello, Menas. Can you hear me?
Yeah, this is Tushar. What was the problem?
Possibly you can remove me from co-host. That's why the slide is not changing.
No. That's not the issue. You just minimize the window and again go to the slideshow. It's
okay.
changing. Yeah.
Okay. Now we have to go. Now this is full thickness tear where the MR sensitivity is 88%. This is the tiny full thickness tear, sparing the articular surface with a minimal retraction of the tear fiber. Here the complete full thickness tear extending from bursal surface to the articular surface, and in this edge image we have to look for measure the anterior-posterior diameter of the tear, because if the tear is less than 3 millimeter, it is called mild. When it is in between the 3 to 6 millimeters, we call this the moderate, or when the tear is more than 6 millimeter, we call it's a severe or severe severe tear. And in the orthopedician also need to know how many anchors they have to need to put here, and also they want to calculate the costing of the surgery. This is the full thickness tear involving the myotendinous junction, possibly caused by the trauma. Full thickness delaminating tear is nothing but a horizontal tear which divide the fibers into the superficial and deep. In our report, we have to put all of these retracted fibers separately, because if the arthroscopic repair occur only the superficial fibers, when patients start to move the movement of the shoulder, then again re-tear occur from the deeper fibers which already neglected. And the full thickness tear communicates, in the full thickness tear, the bursal surface directly communicate with the joint space. And we also look for the acromioclavicular joint due to degeneration. Here, there is a severe osteoarthritic change in the acromioclavicular joint with excessive callus formation, gives the impingement on the supraspinatus tendon. Two more important things we have to look for in case of the tear, that is the muscle bulk and fatty infiltration. The line drawn from the coracoid process up to the spinous process for supraspinatus, and the line drawn from spinous process to inferior angle of the scapula for infraspinatus. If the muscle bulk is above the spine, this is normal. If the muscle bulk touches up to the line, this is mild atrophy. And when the upper border of the muscle is below the line, this is moderate atrophy. When the muscle is much below that line, this is the severe muscular atrophy. This is the normal muscle without any signal changes. If there is any mild fatty streak, this is called grade 1 fatty change. When there is more fatty streak but less than the grade 1, this is type grade 2 fatty change. When 50% muscle is involved by the fatty infiltration, this is grade 3. When most of the muscle is involved by the fatty infiltration, this is grade 4. And at the same time, sometimes the colloid degeneration makes cystic changes, in intraosseous cystic changes, and where it is small or large, we have to put it in our report, because when the orthopedician anchoring here with the suture material, if we did not mention it, sometimes the suture material comes out and there is failure of the surgery occurred. Isolated infraspinatus muscle tendon is very rare, occur in your athletes, seen in all plane. This is the coronal oblique and axial image, shows the diffuse hyperintense signal chain into the intraspinatus muscle as well as joint fluid effusion. Subscapularis tendon tear is also very uncommon, occur in old patients and associated with recurrent shoulder dislocation. Here the retracted tendon is seen associated with surrounding edema and as well as edema into the bicipital group due to synovitis. There is interstitial tear is seen in the subscapularis muscle tendon substance, and delaminating tear into here associated with empty bicipital group, as the biceps tendon is dislocated within the substance of the subscapularis tendon. Here, due to subscapularis tendon tear, we have to look for the coracohumeral distance, as the coracoid process, by the coracoid process, there is impingement into the subscapularis muscle and narrow this distance. So the subscapularis muscles are associated with bicipital tears frequently, as it is postulated that some of the tendon fibers goes through the bicipital group and inserted into the greater tubercle to give the medial stability of the biceps tendons. When there is complete tear occur of the subscapularis tendon, the bicipital group, biceps tendon is dislocated medially near the glenoid cavity with empty bicipital group. So what is the massive tear? When the tear involves more than 2 tendons, or when any diameter when it is more than 5 centimeter, associated with marked muscle atrophy or grade 3 or 4 fatty infiltration. Then we look for the rotator cuff arthropathy, where when the complete tear occur in the supraspinatus tendon, the humeral head is direct contact with the acromion process, and there is marked reduction of the acromio-humeral distance. And look, the undersurface of the acromion appear concave, giving the acetabularization of the acromion. And look, this is the normal greater tubercle. When there is tear from here, this is flat and giving the acetabularization of the humeral head. Now one more slide to see the rotator cuff interval tear. This is the rotator interval between the supraspinatus and subscapularis muscle. Here the coracohumeral ligament is containing the coracohumeral ligament and biceps tendons. When there is tear occur, this area is filled with fluid signal intensity, and the absent coracohumeral ligament or torn bicipital tendon sometimes. And this is the area of adhesive capsulitis, where there is thickening of the coracohumeral ligament and capsule. Sometimes the anterior supraspinatus tear may extend into the rotator interval area. So we have to remember the most important thing is that is the PD non-fat sequence is the base to study the anatomy, and each muscle has to be studied in all plane and all sequences, not only the site of the pathology. And this is the checklist to report a tear, in which tendon is involved and which part of the tendon is tear occur, and what is the actual dimension of the tear, and if there is any associated with bursal fluid or joint fluid, or associated with muscle atrophy or associated with fatty change, we have to mention in our report, because this muscle volume and the fat infiltration has very important prognostic indicator. Because after the surgery, patient need to rehabilitate and to increase the strength and volume of the muscle. If the patient have the higher grade muscle atrophy and fatty infiltration, then patient needs more time to rehabilitate. So one more tips, that is we need to know the better anatomy and pathology evaluation